everybody. Today I want to tell you a little bit about spinal stenosis. Spinal stenosis is narrowing of one or more levels of the spinal canal and subsequent compression of the nerve roots. Most commonly occurring in the lumbar spine, spinal stenosis can be caused by overproductive osteophytes, ligament encroachment, or protrusion of the intervertebral discs. Spinal stenosis may produce symptoms by either directly compressing nerve roots or by compressing the arterioles that supply blood to those nerve roots. Spinal stenosis is primarily seen in adults over 60 years of age, but only a small proportion of the affected population has symptoms. Obesity is a predisposing factor for spinal stenosis, as is osteoporosis and the other risk factors shown. The three most important questions to ask when the clinician suspects spinal stenosis are: to determine the mechanism of onset. Ask, was the onset of pain sudden or gradual? Did the pain start after an accident or a fall? After you lifted something heavy? Identification of a specific etiology can aid in diagnosis. However, a history of trauma or a fall from height raises the risk of spinal fracture. Sudden onset without trauma may signal a serious condition such as a dissecting aortic aneurysm. Number 2, a detailed pain assessment is crucial to diagnosis. We should ask, where did the pain start initially, and where does it hurt now? How long have you had this pain? Is the pain the same as it has always been, or is it getting worse? Pain from spinal stenosis is typically located in the buttocks, thigh, or calf. Spinal stenosis has a very gradual onset and progressive nature, and patients typically have had pain for longer than 6 weeks before seeking treatment. Then we should ask, what makes the pain better? What makes it worse? Does the pain wake you from sleeping? Lower extremity pain that is relieved by rest is an indication of intermittent claudication, which is not in the symptom cluster for spinal stenosis. The pain of stenosis is sometimes relieved by bending forward or stooping. Additionally, patients with spinal stenosis who sleep on their backs will frequently report awakening from sleep after several hours with lower back and leg pain. Finally, we should ask, have you had any bowel or bladder incontinence? Or have you experienced any numbness or tingling or loss of sensation in your legs and feet? Positive answers to the latter questions indicate a neurogenic cause to the pain. Disruption in bowel or bladder function indicates a severe stenotic disease and requires prompt treatment. The top 3 physical examination components needed for adequate assessment of spinal stenosis are to observe the gait and the patient's appearance while sitting upright. Patients with herniated discs usually are uncomfortable sitting and their gait is cautious and awkward. Patients who limp or have an uncoordinated gait are more likely to have significant neurological problems, not simply spinal stenosis. Number 2, we should perform spinal range of motion testing and lower extremity traction maneuvers. Pain that is exacerbated by extension of the spine is often caused by osteoarthritis. Pain on flexion is indicative of disc disease. Leg pain or radicular symptoms with the leg straight raise traction maneuver is diagnostic of disc injury. And number 3, we should check the sensation of the perineum. This assesses for symptoms of cauda equina syndrome or compression of the lower portion of the nerve roots distal to the spinal cord proper. This complication of severe stenotic disease can cause irreversible damage and must remain in the back of the clinician's mind when assessing patients with lower back pain. Medical management of spinal stenosis involves symptomatic treatment for the first 3 months. Unless contraindicated, the patient should receive the appropriate pain medication such as NSAIDs and possibly anti-seizure medication such as Neurontin. Exercise, such as bicycling or walking, and rest when pain occurs is central to the management of spinal stenosis. Epidural corticosteroid injections may provide immediate relief for up to 50% of patients and long-term relief for up to 25%. Any neurological deficit, gait disturbance, or bowel and bladder dysfunction should be evaluated further and require immediate referral. Surgery, such as a laminectomy, should be considered for advanced disease, pain that is refractory to pharmacological treatment, and patients who cannot manage ADLs. Long-term treatment of spinal stenosis is aimed at prevention of further back problems. Patients should receive instruction and information on exercises to condition specific trunk muscles and prevent further injury of the disc and spinal canal. Strengthening of the abdominal muscles is critical to halting progression of the disease. Patient education is of great importance with the diagnosis of spinal stenosis. The clinician must discuss with the patient that back pain, like other chronic conditions, will get worse unless preventive measures are taken, such as the appropriate exercises, smoking cessation, and weight loss if applicable. Patients and family members must be educated to serious symptoms such as changes in bowel or bladder function, changes in neurologic status, and gait disturbances. Stress the importance of immediate recognition and reporting of these events. Educate patients and family regarding the risks of long-term use of and side effects for NSAIDs and narcotics. Thank you for your time and have a wonderful day.